I'm Dr. Jason Williams. I'm a radiologist and researcher at Precision StemCell. We've been for a little over a year now, we've been doing stem cell therapy, mostly image-guided stem cell therapy. Particularly, we were interested in doing more orthopedic work. And so we found good results with doing knees and shoulders, and that was our main focus. And then early last year, a friend of mine knew of another patient, or a patient that has ALS, named Frank Orgill, who used to be a coach at Auburn. And they'd asked me if I would consider using stem cells to treat him for ALS, also known as Lou Gehrig's disease. And at the time I thought, well, I'm not sure if our therapy will be beneficial for this type of patient. I think stem cell therapy has a lot of potential uses, but I think we may be far from something that would benefit patients with ALS, particularly since our stem cells come from fat. And I thought, well, what's the likelihood that would be beneficial for somebody with a neurodegenerative disease? Then as I started kind of researching, because I did want to try to help him out and I wanted to learn more about it, we looked into the idea of using a drug that's actually for Parkinson's disease called Orgill. And there was a study out of Iran that showed that you could take stem cells from fat and expose them to Orgill, and then it would actually help convert some of those stem cells into neural precursor cells. And so we thought, okay, well this might be a possibility. We'll give it a try. So Frank came. He was willing to try it out. We did it, and a couple weeks later, he called me and told me, that he was moving his leg, which he had not moved in years, and was seeing, a lot of improvement and felt better, and was just extremely excited. And when I first, heard about this, because initially he actually told somebody else in the office, I thought this was a joke. I said it's not possible, but we'll find out. When I talked to him for myself and found out, I was really pleased and impressed. I thought, well, gosh, maybe we're on to something here. I don't know exactly what it is we've done, but no other real treatments for ALS have been beneficial. So this seemed very promising, and we thought, well, we're going to have to try to investigate this further. So over this year time frame, we did a few limited patients, and we saw, certain patients had some pretty good response. Other patients, no response. Some patients, maybe they had some slow progression. But the thing that we were kind of realizing was that the patients, when they saw a response, it seemed to be relatively quick, within days to weeks, certainly within, a month or two. And we thought, this doesn't make any sense, because the main idea behind stem cell therapy would be that you would regrow the nerves. And so in ALS, you get the damaged motor neurons, and then with stem cells, theoretically, you're going to regrow new ones. But those take a long time to grow, and so it would be unlikely that stem cells would regenerate new nerves that quick. So it became rather obvious that stem cells were not regenerating nerves, but they were making substances which inhibit the ALS process. And we knew that with that, maybe we could utilize these same substances or enhance the production of it to actually treat ALS. The main thing is we have to figure out what are these substances. So we went, over time, just kind of looking at things, and one of the things was that there's an article that showed that intravenous infusion of mesenchymal stem cells, which those can come from fat or from bone marrow. Mesenchymal means middle tissue, and usually it's going to produce bone, muscle, cartilage, those type of cells. But using stem cells that are mesenchymal and infusing them intravenously in the ALS mouse model showed improvement. So it kind of further supported that using these type of stem cells can be beneficial in ALS. And but again, why? Certainly given it intravenously, it seems unlikely that it's going to get to the brain or the spinal cord. But that study further supports the concept that we have that the stem cells can be useful. Then just recently, it's really been within the past month, the University of Harvard researchers, a guy named Ting, who had been studying stem cells as well, he did an animal study, a mouse study with ALS, and found that if they injected the stem cells into the spinal cord, that the stem cells produce substances which actually cause the mice to live significantly longer, some of them 4 times longer than normal, which was tremendous. But they weren't regenerating nerves, and the stem cells were staying, close to the site of injection, but yet the animal was getting benefit throughout their whole body. And it's a great study, really supports the same concept that we have. When I saw that, I thought, God, at least, we've got somebody else that is saying the same thing that we're saying, and, it's a respected university like Harvard. So this is great. This is really exciting. And the thing is that over this time, I've been looking at it, and some of the things that are kind of coming together, I feel like maybe we have identified some of the substances that are being produced that will inhibit the process of ALS. And so, one of the things, one question is, well, if stem cells will inhibit ALS, then, and mesenchymal stem cells, which you can get from fat or bone marrow, then do you really need neural stem cells, which are more difficult to come by? And we don't really know the answer, but my theory is it's kind of a mix, yes and no. Mesenchymal stem cells are producing certain substances which are beneficial. Neural precursor cells and neural stem cells may be producing particular neural factors which may be beneficial. So the combination between those both of those may be the reason that we're seeing additional benefit. I don't know this, but I think that's quite a possibility. One of the great articles and I've got showing is that you can use selagilin to help basically pre-induce adipose-derived stem cells into neural precursor cells. It's a great study, and this is kind of the same technique that we've used. I've also got a great study from our collaborators in Bogota, Colombia, STEM. They did a study showing that stem cells from fat were far more likely to become neural cells than stem cells from bone marrow. And I think this is very revolutionary, and they've done a great job with this, and we're very excited about the work that we're going to be doing with them. And this further supports a lot of the things that we're saying and the benefit of having fat-derived stem cells as opposed to bone marrow-derived stem cells. You get far more in number, and certainly, the generation of neural cells is going to be better as they demonstrated. So the big question is, what is causing ALS? Now, ALS, the problem with it is very complex, and there could be a lot of different potential causes. So we really have a hard time nailing this down. We know that they have the familial type, which is associated with superoxide dismutase, but that is a very rare number of patients when you look at the overall number of patients that have ALS. So then you've got to look at other possibilities. There's one real hot area right now is a protein called TDP43. It seems to definitely have some involvement. The question is it too much TDP43 or is it too little? Both seem to cause ALS in the mouse model. So I think when you look at it overall, it's probably too much that's accumulating into the cells and is becoming neurotoxic. But it's difficult to know, and it may be different for different patients. But one of the things that it seems to be is that no matter what the cause from ALS, they all lead to one particular mechanism. There's one common road, and that is a thing called complement. And complement is part of the immune system. It's actually one of the more primitive aspects of the immune system. Very important for helping us to fight off bacteria, but also, it eliminates debris and other dead cells within the body. It's involved in that as well. And I think that what happens in ALS is that complement has gone awry and it's attacking some of the patient's normal cells, their motor neurons. And well, initially this kind of came to me when I was reading an article in the journal Science, and there was a guy from Stanford, William Robinson, who did a study, and he found that complement was involved in causing osteoarthritis, wear and tear arthritis, which is what most people think, well, that's just from overuse, where he showed that complement was actually causing a lot of the damage. So even though there may be a wear and tear component, but if you inhibit complement, the joints seem to do better. They seem to have less damage. When I saw that, I thought, wait a minute, well, we use stem cells for joints. We see that the patients seem to get improvement of their pain right away, before they've regenerated any cartilage, before their joint looks any better. And I thought, how could this be? And then our ALS patients, of course, are also seeing improvement, right away. Is this just a coincidence or not? But it seemed that maybe it was a similar mechanism. So I decided to do, a little search and find if there was a link between ALS and complement. Sure enough, I came up with 2 articles where people actually had studied this. One was the article that we've got pulled up now, where it shows that if they inhibit complement in the ALS mouse model, then the mice would live longer. That further supported this idea that complement is involved. And so obviously if you can inhibit complement and you can improve symptoms of ALS, if you can extend life in the mouse model, then that seems very promising, again, that complement may be involved. There's another article which showed that complement was attaching to the nerves, to the motor, the neuromuscular junctions, the junctions between the nerves and the muscles, and attacking as well, and associated in ALS in the mouse model. So further supporting the same concept. Then just kind of searching, other literature, I found evidence where complement was elevated in the spinal fluid of ALS patients. It just was kind of incidentally mentioned, but nobody really knew the significance. And even in these studies with the mice, they mentioned the complement involvement. They mentioned it as a possible target to treat ALS, but it really didn't get carried much further than that. So the slide I've got here is a illustration that shows the nerve, and then it shows complement binding to the membrane of the nerve. And essentially, complement will start binding and builds up and then begins attacking and destroying the nerve. The next picture shows a very good kind of correlation to this. It's like barnacles on a ship. So as you get more and more barnacles, they begin to eat through the paint, cause rusting, get holes in a boat, and it can sink. The same type of thing with complement. The more and more it binds, the more it kind of essentially eats holes into the membrane, and initially it may stun the nerves, so the nerves don't function well. So patients that have ALS, their nerves, some of them may still be alive, but complement's bound to them, and so they're not functioning as well. Then when you give them stem cells will help remove some of the complement, and so those nerves that are stunned begin to function again. And so that's when the patients will start to find that they're able to speak better or able to walk better, strength is improved, things like that, because the stem cells are able to salvage these damaged nerves, but they're not dead. Of course, as the process goes on, the nerves become dead, and then that is a whole new problem. And so one of the real importance that stem cells initiated earlier in therapy are more likely to salvage nerves. I think that was very well supported by the Harvard study, where they initiated therapy very early in really probably before even symptoms, which you can't, in a human it's very difficult because most of the time patients get diagnosed, and sometimes it takes a while to even know the patient has ALS. So it's very difficult to initiate therapy early, but as we can see, that's a real key, that you need to be able to start therapy as soon as possible to reduce that potential attack on complement. So the big question was, how can you inhibit complement? What would kind of stop it? I mean, there's been some development of drugs that can inhibit complement, but the problem with a lot of drug therapy is if you think of complement attacking the nerves 24/7, but a drug may only be in the system briefly, minutes, hours at the most. So it helps, but there's still a lot of a time for the complement to continue to attack, and it just doesn't treat long enough. You need something that's continuously there, something that is continuously inhibiting complement. And that's where a substance called factor H comes into play. Factor H is the body's regulatory mechanism for complement. Factor H, of course, is going to inhibit the attack of complement and inhibit the damage to the neurons. Mesenchymal stem cells produce factor H, and so that's why when we see patients who are treated with stem cells, and of course particularly mesenchymal stem cells, but we believe that many types of stem cells probably produce factor H, and we don't really know which one produces it more, but certainly it's quite possible neural stem cells, other stem cells are going to produce it. So really we're talking stem cells in general, but of course in our study we're looking at mesenchymal stem cells. But one of the things that was interesting is that factor H production in stem cells are inhibited by giving non-steroidal anti-inflammatory drugs. That basically was shown in the study with stem cells and factor H. And interesting enough, in retrospect, if we look at some of the patients who didn't really seem to see much of a response, but we would have thought maybe they would, several of those patients were on non-steroidal anti-inflammatory drugs, or were given them, and we just didn't know at the time. But now we know. But that further supports that factor H is involved in this improvement. So the next slide shows a good example or an illustration showing the neuron, showing complement bonding to the membrane, and factor H binds next to it and basically pulls it off, removes it from the neuron, so it regulates complement. Then the next slide shows just an illustration of mesenchymal stem cells producing factor H, shows the complement bound to the neuron, to the membrane, and factor H removing complement. The next slide shows stem cells producing factor H, essentially signified by a shield deflecting complement from attacking the nerves. So essentially stem cells are protecting the damage that would be caused by complement to the nerves. And so one big question in stem cell therapy, and particularly some of the current therapy that we've done using the adipose-derived stem cells, is why do some people see benefit and other patients don't? And I think one thing is that some disease process for ALS may be very aggressive. So even though stem cells go in, they produce factor H, they're trying to inhibit the underlying cause of ALS, the disease is too relentless, too aggressive, and the stem cells are just not enough. They're not producing enough. You don't have enough cells, so you can't overcome that attack from complement. And the other thing is that some patients, they've had a lot of damage already from complement, and the nerves have been damaged, and so when you go in, there's just not as much stuff to fix. A lot of the nerves are dead, and the other nerves are, there's not as many stunned nerves, and so the patient just doesn't really see a big benefit from that. But one of the big things I think is that the attack of complement is just far outnumbering what the stem cells can produce, and so it's another angle of attack. We've got to figure out how can we keep the benefits of stem cells continuous, long lasting, and increase that too, make it a much higher percentage. Because when we're looking at it now, the stem cell therapy may produce a small fraction of the benefit. We need to boost that. We need to boost it tens, hundreds, maybe even thousands of times more than what it is to really see a great therapeutic benefit in these patients. We know right now that some of the patients see improvement, certainly some of the patients see slow progression, but this gives us the initial idea, but we've got to take that same concept and take it further. This is just the first early step. We've got a ways to go, but I think we have some good direction. I think we have a better understanding of what's happening. So certainly when you look at the substances that are produced in stem cells that inhibit the process of ALS, I feel factor H by far is probably the most important. But there's several other factors that we're looking at that we feel are key components to this. Several neurotrophic factors, nerve growth factors, other growth factors. Some of these have been studied individually in the ALS mouse model, things like IGF-1, hepatocyte growth factor, those type of things that individually in the mouse model were shown to slow disease progression, extend nerve life, extend life of the animal. And so we feel that maybe a whole concert of several of these things together could be the way to go. Factor H being the most important, but several others being also, added components as well to show some additional benefit. So as I mentioned earlier, one of the big problems, if you looked at just injecting factor H, insulin-like growth factor, those type of substances, their half-life is so short. So it goes in and then sometimes in minutes it's gone. The only way that you would really be able to see good benefit would be a continuous infusion of these substances, and probably a continuous infusion into the spinal fluid. And that, is going to be a problem, and it would be really difficult for somebody to be able to continue to do that. We know that the stem cells are producing these substances, but how long? It's probably not enough. It's probably for a period of time, and then that's going to fade. So how can we enhance this? How can we make it where these substances are continuously produced at the level that's therapeutic? And that's when we get into the concept of gene therapy. Gene therapy, of course, the idea and promise has been around for a long time. But now I believe gene therapy's day has definitely come. Over the years past, and previously I've done research with gene therapy in cancer, did a lot of work with adenoviruses. In more recent years, I've been doing a lot of work with adeno-associated viruses. The work that I've been doing over the past 5 years was really more focused on muscle wasting conditions and muscle wasting of cancer. And so we looked at that and we developed a nice platform of gene therapy using an adeno-associated virus. But we can take that same concept and we can apply it in ALS and apply it with these same factors. Then we can take and we can genetically alter not only the patient's existing cells, but we could also combine it with the stem cells as well. And so this could be a good therapeutic treatment that once it puts these genes into the cells, they will continuously produce these substances, and it'll actually help treat the whole process of ALS. And so I think that this is really the key component. Then when you look at it and you look at the problems of trying to do gene therapy, one big issue is how do you get these genes into the cells? There's various viral vectors that you can use, but usually none of them are perfect. They all have their problems. But in recent years, the adeno-associated viruses have really come on strong and seem to be the future of all gene therapy. But one thing interesting enough, and as the article I've got shows some work actually from my alma mater, LSU, that they use the AAV9 adeno-associated virus, and they could actually use it and it would transfer the genes throughout the brain and the spinal cord. Injecting it intravenously, it would work, but injecting it into the spinal fluid, even better. And this is a great delivery mechanism. This is perfect for what we need for a condition like ALS, and of course other neurodegenerative diseases as well. And that's kind of what they said. They said, hey, we figured this out, that this is a great delivery mechanism. It'd be a great way to deliver appropriate therapies. So AAV9, very key, very important. Another article showing the same type of thing, that you can use AAV9 to deliver genes throughout the central nervous system. It actually can evade neutralizing antibodies. So a lot of people have been exposed to viruses, and with gene therapy, if you administer a virus that the patient's been exposed to, they will kill it off, and the gene therapy won't be very effective. It won't get a chance to work. this can actually evade the neutralizing antibodies and still deliver the gene to the nervous system. Very key, very important. This means that this could be very useful for almost the whole host of patients. You don't have to worry about the antibodies. So this led us to the development of a new concept of treatment for ALS and a new gene therapy using the PRCN829 AAV gene therapy. This is a kind of multi-platform gene therapy. It's a combination, multiple AAVs, multiple types of AAVs, multiple genes, different target points in ALS using several key factors. I think that when you look at therapy for diseases, where a lot of people make their mistake is they want to find one answer for the disease, one drug that cures it, one treatment cures it. This is a multi-pronged approach, but wrapped into one thing. So even though technically it's like one drug, but really it's probably like 6 or 7 drugs into one. And when you look at other effective therapies, it's very common that you have to use multiple drugs to get effective treatment. HIV is a great example. When they first started treating HIV, they kept looking at individual drugs. Then when they finally got to the point where they combined several different drugs together and realized that was an effective treatment. Individually, each one alone didn't really do that much, a little bit of help. Together was a great treatment. I think we've got a similar concept here where we've got several potential genes to target, several things that will be beneficial. I think you put it all together, and I think you're talking about a real effective therapy for ALS. And what this will do, it'll inhibit the attack from complement, it'll provide neural growth factors, it'll provide other factors, it will, can even have involvement with the TDP-43, a whole host of different options of treatment. I think is very powerful. Then the other thing is that we look at the combination of gene therapy plus stem cells. So we can take the stem cells, we can genetically alter them with the gene therapy. Then we can administer those stem cells, plus we can genetically alter by administering the gene therapy to the patient. So the patient's existing cells get it, the stem cells have it as well. They all work as a factory to produce these different biological therapies to treat ALS. So we're currently in a joint collaboration with STEM in Bogota, Colombia, Precision StemCell in the United States, and Precision StemCell in Latin America. And we're going to focus a lot of our research efforts doing the mouse study that we've got lined up, studying these genes, studying this gene therapy, studying stem cells, studying cultured stem cells. We've got a whole host of different plans. We're going to have various arms for treatment to study all the different possibilities, and we're very excited about this. One of the things with the researchers in Colombia is that we felt it's very important to do this study, to follow it closely, but to be able to transition into human work right away. ALS patients, they have no time, so we've got to get this in human use as soon as possible. The next slide just shows kind of an example, the gene therapy, this thing that looks kind of like a spider, sticking onto the stem cell, injecting the genes into it, and then you can see where the stem cell is producing tremendous amount of factor H, tremendous amount of growth factors, and so increases that therapeutic response. The next slide shows the gene therapy binding to the neuron, putting the genes in the neuron. The neuron itself, the nerves, are producing factor H to protect itself. They're producing growth factors to further inhibit neuron death. And so you're giving the nerves their own cure. They're making their own therapy. And so very unique idea. The next slide shows kind of the shield of the PRCN829 gene therapy inhibiting the attack of complement from ALS of the nerves. And so initially we'll plan to do the study with a superoxide dismutase mouse, and that study will be performed in Bogota, Colombia. We'll do that study. We estimate a time frame of about 8 months to get an idea of efficacy, and then immediate transition into human work. We really feel that the results of this will be so powerful that we've got to get to human therapy as quickly as possible. I've got too many patients that are counting on this, and I can't let them down, and they don't have time. So we don't have 10 years to wait. We don't have 5 years. We've got to do this right away. And so that is kind of, we have a real sense of urgency to get this done, and I can't let these people down.